So good morning, everyone. Today we continue with our case presentation session. We will start with this case of 37-year-old female patient presented with secondary infertility. Her exams were normal, so hysterosalpingography was ordered for her. First of all, do you see any fallopian tubes or spillage or whatever?
No,
So bilateral fallopian tube is
obstruct. Yeah, but it's not the normal shape of the uterus, not the triangular shape of the
okay.
endometrial cavities.
Awesome. So what's the problem here? The uterine cavity is abnormal shape. It appears elongated
Yes,
rather than triangular. What
not
else?
filled regularly.
يعني شنو not filled regular?
كأنه adhesion كأنه وحده adenomyosis يعني.
First adenomyosis, you don't see it by hysterogram.
I don't see it, but there will be abnormal filling also.
You don't see it? What are these lines you see in the endometrial cavity? You see these lines, these things here? These most probably adhesions.
Yes.
Adhesions in the endometrial cavity, what is called? Synecdoche or Asherman syndrome. This is very typical Asherman syndrome due to endometritis. So old endometritis with adhesions. Yeah, and it appears of this shape. طبعا secondary infertility due to I don't know. She had I think IUCD for a long time. I'm not sure, but I think. Okay, nice. Well, so this is a case of a young adult female patient. I think she's around 20 something years old, presented with repeated vomiting or upper abdominal pain. يعني interrupted يعني attack of vomiting, upper abdominal pain, then normal, then and so on. So ultrasound was normal. CT and did not respond to treatment, so CT scan was ordered for her. 20 something years old, 22, 23, something like that. So CT scan, abdomen, pelvis with, you see the whole abdomen. You try to locate some sort of abnormality or something, and then you focus on it and
both kidneys normal.
شوفي first you take a look at the entire exam. Then you decide the kidney is normal, the liver is I don't know what.
It's look normal.
Okay.
Spleen also.
Mm-hmm. Where? The typical jejunal intussusception. You can see the fat between two layers, and if you go to the tenilmos, and if you go to the coronal image, you cannot unsee it. Obvious or not obvious? It's typical intussusceptum, intussuscepient with fat, mesenteric fat in between. And this explains the intermittent pain and vomiting because small bowel intussusception is usually transient, intermittent. It comes, she's in pain, she's vomiting, she's I don't know what, and then it resolves. And then it comes again and it resolves, and so on, so forth. So they have to, usually there is a leading point, like a polyp, I don't know, something that is leading point. And we will, most of the times, we don't see the leading point by imaging, by CT or MRI or whatever. So they go, they open this part and they dissect the abnormal part with end-to-end anastomosis. Okay? So this is a straightforward jejunal intussusception. And that's why you don't see any signs of intestinal obstruction. طبعا بعد it's there's no intestinal obstruction like all the time. It's just moments. Comes and goes, comes and goes. Yep.
Nice.
40 years old male patient presented with long history of vomiting and regurgitation and things like that. What is the exam and what do you see and what would you just scroll, don't do anything. What's this exam?
Barium Swallow.
Barium Swallow. Excellent.
Showing dilated esophagus.
Mm-hmm. Whenever you see, you said till now, barium is barium swallow with dilated esophagus. Whenever you see dilated esophagus, what do you look for? You look for the end of the dilatation. Where does it end?
Gastroesophageal junction.
So it ends at the gastroesophageal junction. So the entire esophagus is what? Dilated to the level of the gastroesophageal junction. The question is it obstructed or not?
Not.
It's not obstructed. Contrast, it's passing to the stomach. So contrast is passing to the stomach. Now, the level of obstruction will help us determine the cause of obstruction. So, the shape of the at the end, is it an apple core lesion?
No.
Is it what?
It's rat tail.
Rat tail appearance. It's smooth and it's gradual. You can just open mouth, go like that. Give me. It's smooth and it's gradual. Okay, and if we little bit change the window to make it harder, maybe like this, I think, darker. Okay, you can see that this is the end. What do you think is the most likely cause in this case?
Achalasia.
Achalasia. Primary or secondary?
Primary.
What are the causes of secondary achalasia? احنا الكوز الوحيد للسكندري اكاليزيا هاي تشاداز ديزيز اللي هو وين هاي بالبرازيل وبالارجنتين وبتشيلي يعني احنا ما عندنا تشاداز ديزيز نهائيا. It's some sort of parasite. We have no secondary achalasia. We have mostly primary achalasia. And in fact, this case has been suffering from this achalasia for maybe 6 or 7 years with recurrent. They do dilatation and re-achalasia and dilatation and re-achalasia. So it's just a basic, simple primary achalasia showing the rat tail appearance with dilated esophagus. And I think if you look carefully, of course, there will be some diverticuli. If you look carefully, you can find some food particles trapped into the esophagus. The thing is that we have normal esophageal mucosal outline. There is no irregularity to suggest, for example, candidiasis, esophageal varices, other things that can be seen on a swallow. Okay? It's just primary achalasia.
Okay. Brain MRI, T1, without contrast,
Nice.
showing dilated dilated ventricles reaching to the
يعني hydrocephalus?
not hydrocephalus, but as it's the post-op case, so
Cerebromalaysia.
that's a revelation.
Polycephalus, as you like. المهم انه these are not dilated.
No.
This is ex-vasodilatation due to loss of volume, loss of body time, brain.
There's a well-defined high signal intensity oblong lesion extending from the frontal region toward the right ethmoidal and nasal cavity, which is high signal in T1.
hyperintensity T1 and T2 زين وبال
فلير وين فلير سبريس
يعني fluid. The question is سمي لك هو surgery for olfactory group meningioma. So when you say follow-up MRI, we are looking, is there any sign of recurrence or not, or residual disease? So do we have recurrence or residual disease or not?
I think it's post-operative sequelae, hematoma, or because it is
سؤالي, do we have residual disease or recurrence
no
or not? What would you report?
operation for how much?
Maybe 3-4 years.
3-4 years.
It's not recent أكيد يعني.
But it is T1 high. I think it's all hematoma here. No.
ما جاوبتني. اكو recurrence ولا؟
No recurrence.
No recurrence. زين. So what's this something, the bright thing? It's hyperintense on T1, it's hyperintense on T2. Okay? The question is, how do we explain the appearance here in the flare?
It's high in T1 and T2.
Okay.
Suppressed on flare.
Okay.
Suppressed on flare. Maybe fluid loculation, but
Fluid. What fluid appears hyper on T1?
Victor, not fluid and not fat. Maybe fat. T1 high, T2 high, maybe fat, but why flare suppressed? What about stare?
So it is what here?
High.
This is what?
T1.
T1. And what's this?
T2.
And it is
Still high.
less hyper.
Yes, hyper.
So hyper, less hyper. What does it appear here?
Flare suppressed.
Suppressed. So how do we explain that? It's a flare fat sac. And just look at the subcutaneous fat here, subcutaneous fat here. It's hyper, less hyper, dark. It is not only flare, it's flare fat saturated. So this is a fat. The question is, شنو الفات اللي what's the fat that comes in this location? يعني lipoma, This is fat packing. They do in the surgery to close the defect. We did that. We put the fat pack in the defect when we remove the meningioma to close it. So this will stay there forever. It's just normal fat. The surgeon used it to close the defect. يسموه fat packing. Sometimes they use fat, sometimes they use muscle, sometimes they use both fat and muscle. Okay? Surgical, post-surgical case, which is he was very normal and thank you very much.